Hey, welcome back to Not So Complicated, and today we'll try to uncomplicate nephrotic syndrome, its pathophysiology, types, clinical picture, diagnosis, and management, right? So we'll try to give you the clear concept and last-minute revision notes also. So nephrotic syndrome is the combination of nephrotic range proteinuria with a low serum albumin level and edema, right? So what is actually nephrotic range proteinuria? It is the loss of 3 gram or more per day of protein into the urine, that is in 24-hour urine volume collection there should be more than 3 gram of protein, right? Or if you are calculating in a single spot urine collection, there should be the protein or albumin to creatinine ratio of more than 2. All right, so that is what nephrotic range proteinuria is, and this is the overview of the nephrotic syndrome. We will be talking about each of them in detail, like injury to podocytes, how that happens, right, and how the protein leaks happen, and the signs and symptoms. There is a mnemonics for that too. We'll be talking about that, but first let's talk about the types of nephrotic syndrome. So there can be like primary nephrotic syndrome or secondary nephrotic syndrome, and in primary the types are minimal change disease, which is the most common one. Almost 76% of the pediatric children will present with minimal change disease, and focal segmental glomerulosclerosis is the another one, and another one is membranous nephropathy, right? And in the secondary reasons, there is diabetes first, and the diabetes will lead to nephrotic syndrome via glycation injury, and in lupus nephritis there is immune complex deposition, and in amyloidosis there is protein deposition, right? So these are the types of nephrotic syndrome. Talking about the pathophysiology of nephrotic syndrome, what actually happens is that the glomerular filtration barrier, what is in normal condition, will get damaged, right? And we'll be talking about how that gets damaged in 3 different reasons, 3 different ways. These podocytes with their slit diaphragms, the normal function was to maintain selective filtration, but that will be compromised in nephrotic syndrome, right? The ways are 3 of them, like this. The first one is cytokine mediated damage, that is interleukin 13 in minimal change disease, right? And that will lead to podocyte food process effacement, reducing negative charge. Talking about this negative charge, what actually happens is that the glomerular membrane has negative charge, and the proteins also have negative charge, right? And in normal cases, what actually happens is the negative charge of glomerular membrane will repel the proteins, and that is how the filtration of proteins cannot happen. The one reason is that, and another reason is the pore size in the podocyte is like quite smaller in normal cases, and that is how the proteins don't get filtered. But in this case, this pore size is increasing due to food process effacement, and reduced negative charge will like decrease the repulsion of that proteins, and that is how the protein filtration will also increase, right? So that is how one thing happens. The another reason is immune complex deposition or autoantibodies like anti-PLA2R in membranous nephropathy, that will lead to the activation of complement C5b9, injuring podocytes again, increasing pore size, right? The another one is metabolic stress, as in secondary nephrotic syndrome, as in diabetes, right? That will upregulate vascular endothelial growth factor, destabilizing slit diaphragms. So these are the reasons, these are the ways of damage to the glomerular filtration barrier, right? So how that will lead to the symptoms? Let's talk about the pathophysiology of the symptoms. Now proteinuria is happening, that is especially albumin. So there is hypoalbuminemia, that is the reduced albumin in blood but increased albumin in urine, that is how hypoalbuminemia, and hyperalbuminuria or albuminuria, you can say that, right? So that will lead to, we all know the function of albumin is to maintain oncotic pressure, and the function of oncotic pressure is to maintain the like edema, or just like that, right? So talking about Starling forces, I have made a video, just 1 minute video to uncomplicate this Starling forces. You can check it out. So depletion of albumin is leading to lowering of oncotic pressure, that will cause edema, that is anasarca in clinical words, right? This edema gets exacerbated in another way also. What actually happens is that there is decrease in plasma volume, that will lead to activation of RAS system, that is renin angiotensin aldosterone system, right? And that will lead to sodium and water retention, and thus edema is exacerbated, right? So this is the clinical feature, that is edema, the most common one and the most important one. And since there is decrease in protein, the liver will try to compensate that protein loss, and in that way there will be compensatory rise in lipoproteins, especially ApoB100, that is responsible for hypertriglyceridemia, right? So that is how hyperlipidemia happens in nephrotic syndrome, and these lipids, if they get leaked into the urine, that will lead to lipiduria. So these are the clinical picture. These are the clinical features and the pathophysiology behind that, right? So talking about clinical features in detail, you can remember with a mnemonic that is not nephrotic, that is nephrotic, right? So NAPHROTIC, that is how you can remember. The N is sodium decrement, that is hyponatremia, that is false, that is like false hyponatremia, that is dilutional hyponatremia. There will be increased in water or water volume or plasma volume, that will lead to the decrease in concentration of sodium, that is how dilutional hyponatremia will occur. The A is albumin decrement, that is hypoalbuminemia, and P is proteinuria, that is greater than 3.5 gram per day. H is hyperlipidemia, that is greater than 200 mg per day, and R is renal vein thrombosis. O is orbital edema or periorbital edema, and this is the first to appear. So you have to assess where the edema is appearing at first, right? So if that is appearing at the eyes, the most common causes behind that is kidney disease. So it will first appear in face, then in limbs, then in body, right? So that is how it will progress. And the other T is thromboembolism, and I is infection, because in urinary region there will be loss of immunoglobulins, which are specifically used to maintain the immunity of the body. That is how infections will occur. And also coagulability is the another clinical picture that is due to antithrombin 3 loss, that is III. Antithrombin III loss will be there in the urine. That is how coagulability is the another clinical picture, right? You can see the picture here, that is the case of edema, periorbital edema, right? So, and this is the limbs. You can see the pitting edema right there, right? So if you assess the edema type and if there is non-pitting edema, that is due to lymphatic obstruction, and if there is pitting edema, that is due to the disruption in the stalling forces, right? So that is what you have to remember. Talking about the treatment of nephrotic syndrome, if there is cause-specific treatments in minimal change disease is steroids, that is prednisolone, and in FSGS, that is steroid cyclosporin in refractory cases, and in membranous, that is rituximab and steroids again. And in secondary causes, you have to treat the underlying condition, that is diabetes control and diabetic nephropathy, right? So the supportive treatments are ACE inhibitors, that will lead to decrease in proteinuria, and statins, that is to decrease hyperlipidemia, and diuretics to decrease edema, right? So this is the diagnostic criteria for nephrotic syndrome actually. So urine protein creatinine ratio is greater than 2 mg per mg, right? 24-hour urine protein should be greater than 40 mg per meter square per hours, right? And urine albumin, that should be greater than 3 plus, and serum albumin, that is less than 2.5 gram per deciliter. Edema is generalized pitting starting from the eyes, that is periorbital region, and cholesterol is greater than 250 mg per deciliter, but we consider 200, right, in children. So that is how we cover up our nephrotic syndrome, and subscribe for more, and thank you for staying with me. Thank you so much.